Oh, gosh. It's just me. Hi, welcome back. So we are pivoting to H84. If the committee members that were here last year recall, we did a walkthrough of this bill last year. We took a little bit of testimony on it. Then throughout the session, other things came up. But I'd like us to look at this again. So we've got Jen to do a refresher walkthrough on this.
Good afternoon, Jen Carby from the Office of Legislative Counsel. We're going to look at H84, which I will put up on the screen right now. Right. It's a short bill. It's 2 pages, but 1 page is just the co-sponsors and the statement of purpose. So this is kind of summed up in the title, an act relating to allowing telehealth appointments to be recorded with patient and provider consent. And you can see there's 2 fairly similar sections. Sections 1 and 2 are amending existing statutes relating to the provision of healthcare services through telemedicine or by store and forward means. That's the first section, and by audio only telephone. That's the second section. And in both cases, in existing law, there is a prohibition. It said under current law, the not underlined part says neither a healthcare provider nor a patient shall create or cause to be created a recording of a provider's either telemedicine or telephone consultation with a patient. And then this would add language in both to say, unless both the patient and the provider consent to the recording. So currently there is a prohibition on anyone recording a telemedicine or audio only telephone appointment. If this language were to go into effect, then recording would be allowed as long as both the patient and the provider give their consent. It would take effect on pass.
Shortest walkthrough in the history of walkthroughs.
No, I would put it down in 5 minutes.
Okay. Can you refresh us of what kind of the definition of telehealth is, store and forward is, and audio only?
Yes, so I may pull some of these up, but so under existing law, telemedicine it was harder to explain before we started doing things remotely, but basically like the Zoom. So the remote audio video connected consultation between a patient and a provider. So you can see and hear, but you're not in the same physical location, and the patient can be anywhere. When it first started out, they had to be in a healthcare facility, and it's been amended many times over the years to say patient can be anywhere. So that's telemedicine. So that's real time audio video. Store and forward is when information is captured in some form and given to a provider to review at a different point in time without the patient present, and there's no audio or video connection or interaction required. And that's not affected by this recording piece. It's sort of arguably part of it anyway for store and forward. And then audio only telephone is what it sounds like. It's just a phone call. So just audio, not audio and video.
Should have asked Sebastian to bring his whiteboard back then. I just remember he had a telephone with like the curly little cord on it. Any questions for Jen?
Statute's not up there, but like it says that this would be adding a phrase allowing for a recording to be made with consent, but I don't see any further language about the use of the recording. So that means if we pass this bill without any guardrails, the recording could be used, the data collected in that recording could be used in any way.
Well, I mean, from the provider side, in any way that complies with HIPAA, they still have requirements around confidentiality.
And so questions I have that we may not be able to answer today, but we might want to get answered before we vote on the bill are around how data in these recordings are going to be used by artificial intelligence systems and the companies that make them once consent is given, and how much information are both provider and patient going to have about how that recording is used once it's given, once it's taken. And so without going down like the matrix rabbit hole too much here, like with this stuff, the intent might be to screen the recording and pick out clinically relevant information and then use like a generative AI or whatever text to like, whatever it's called, I may be using the wrong term, to create some kind of textual representation of a conversation that a human reviews and says, yes, or let me correct this thing it got wrong. And that's now the note. But are we also letting these companies take our voice and use data from our voice to analyze emotion that they are then integrating into other products? Or are we allowing them to track us as individuals in a way separate from that medical record? Because that stuff, is that covered by HIPAA? Is that covered by high tech? Is it covered by the new law, which name I can't remember, that came out because there's a new one, a new federal law regarding AI and healthcare. It was in training I did recently for UVM Medical Center. Yeah, it's it has to do with, like, it's the law that says that a patient portal, like your medical record needs to be instantly available to you now. I don't know. We can look into this. The
Yeah,
point is
great.
that
Look at
that
it.
simple phrase, it may seem like it's like harmless, but if we don't look at how the recording is used, then it could cause unintended harm down the road because of the lack of regulation of artificial intelligence systems and how they might circumvent law because they are like evolving so quickly. Anyway, I'll stop there.
Yes, to be clear, this was the request from the original sponsor. This is the bill as introduced, was simply to allow patients and
Yeah.
providers to consent. This is not,
We can't.
doesn't
No, I guess what I'm saying
limit
is,
this
I
committee.
was clarifying that indeed, this does not have guardrails around all that stuff.
No, to the
Right, so I would
extent, to
like-
the extent that existing state and federal laws apply, no, this does not create guardrails around what is done with that recording.
All right, that's all.
Leslie.
Not to like.
So I don't think this is a question for Jen necessarily, but I'm curious to know why the sponsor, sometimes we have sponsors come in and say why they wanted a bill. Like, I'm not sure what this problem, this bill is what problem this bill is solving. I don't-
Well, thank you
Oh my
for
God, so many.
teeing up our next
Yeah.
witness.
Okay, great, thank you.
You know how many problems?
Any
this
other
could have
questions
solved?
for Jen on the brevity of the language?
That's a hard
All right,
one, right?
Fred.
What is the definition of recording? I'm just.
Thank you.
All right, so Justin, want to come on up? I just want to, okay, I'll level set here. We took this up last year for all of about 2 hours. And frankly, I'm still a little traumatized by, I asked Justin to come in because I think that we need to level set with the committee things around what is your medical record? What goes into your medical record? How is your medical record developed? What happens to it once it's out there? And this bill was brought forward because it's funny to hear Jen talk about, like store and forward and all, because that was such a foreign concept 5 years ago. And now I think we all realize how integral it has become in our healthcare system. And in fact, having to do with affordability and access and how it's been able to help us with that. So I asked him to come in and share with us why this bill is necessary and what's going on now and how all of this works. How does this work? What is an EMR?
Well, thank you for having me first. So I'm Justin Smith Donnelly. I am a physician. I work for UVM Health in the capacity of the Chief Health Information Officer. So in that capacity, I oversee IT team that support our overall clinical and revenue cycle suite of IT applications. I have been a physician in Vermont since 2010. I was trained at what was Fletcher Allen at the time, so at UVM in internal medicine. I then went from that training to Central Vermont Medical Center, where I began my attending practice in adult hospital medicine and continue in that practice at CVMC to this day. Along the way, I started to get interested and did work kind of in the intersection of care delivery, how we provide healthcare, and honestly, technology. And it's been a really fascinating and exciting 15 years in that space. And I think I'm sure this committee can appreciate how that space is only accelerating at this point, as we have a whole suite of different tools that we, in my opinion, have a very important role, that this group has an important role. Me and my teams and healthcare systems have an important role to really understand how we leverage these to impact the healthcare and our ability to deliver healthcare in an affordable way to our friends and neighbors. So that is my driving force behind this, is that I truly believe that when appropriately deployed, technology can be a net positive impact on the ultimate health outcomes of the people that we serve. I'm board certified in internal medicine, and I'm also a board certification in what's called clinical informatics, which is a fairly new discipline, which is really focused on that intersection, because you can't solve any problem with only technology. And a lot of times people need technology in order to solve problems. So the intersection between those two groups is critically important. And how you actually implement and deploy these sets of solutions really matters to the outcomes that you will achieve. So it's from within that framework that I'm just approaching, and I'm happy to answer questions along the way. What I was hoping to do with the committee today is to walk you through a set of about 11 slides, just to share a story that we have had specifically related to a technology called ambient technology, which the member had already kind of referenced a little bit about creating notes after recording from voice. And so this is a technology that we're utilizing today. I'd like to share the impact that that technology has had predominantly on our provider population, but also on patients. And then we can actually do a quick demo. I would open it up to members of the committee if you would like to be my patient. We can do a very simple visit where I will interview you, we'll record it, we'll show you how it appears. So if anybody is willing for that, sure, fine. And that'll take about 5 minutes. And then with the remaining time, I didn't come with slides to answer the question of what is an EMR specifically. That is a very, very broad topic. But I am eager to hear your thoughts on what would be helpful, or any questions that I may be able to answer, or in the future, bring additional subject matter experts that could answer them for you.
Okay.
Sound good?
Sounds great.
All right. So let me get Zoom. Okay, it's there. So I did my introduction. So what is ambient? And you're going to hear a couple different words here, but I tend to reference this suite of technologies as ambient. You might also hear the word Abridge. Abridge is the vendor that we have contracted with to deploy ambient technology. So ambient, I view as kind of the overall framework for this type of technology. And then Abridge is a specific, one of many actually, companies that deploys this technology to healthcare systems. So at its core, this technology does use artificial intelligence. It uses large language models specifically that are trained and have engineered prompts to generate a clinical note based on audio input. So that at the core is what we're talking about right here. Sure. So a large language model is something akin to what you might know as ChatGPT or Google Gemini. And yeah, so I'm going to.
Thank you.
So this solution set provided within these tools is not static. So each company continues to evolve their product to try to solve problems that providers experience in their day-to-day lives when it has to do with documentation burden and what I would call the friction of practicing medicine in today's electronic world. And so, I have no doubt that this will continue to evolve over time. And excitingly, additional features will become available to our practicing providers. And the whole goal is to reduce kind of the documentation burden that they experience. This can be things like the different type of specialties that are supported specifically within the application, different languages. So they have more than 20, I think up to 30 different languages that they're able to handle now, leveraging technology. Visit types, so we talk a little bit about telephone visits, or maybe well child visits, or different specific visit types that they're able to support. Personalization of documentation templates, so your documentation looks and feels the way that you want it to look and feel. Actually queuing up orders for review. So instead of me having to go back and change my focus from, the patient that is in front of me in an exam room or in a hospital bed, I'm able to kind of speak that out loud, and then it will actually queue it up for me kind of to go and review, and then I ultimately will sign it. And then finally, there are coding recommendations that it will make as part of this overall suite of technologies. So at a really high level, the workflow is fairly simple. And you'll see this here in a moment when we do the demo. But the first step is to obtain permission. So many things that we do in medicine, we obtain permission for today. We obtain permission to do a physical exam. We've heard, to have the conversation, to share our clinical knowledge and assessment and plan with you. So that's how it starts, and I'll show this here. Then you basically put the secure device down and you have a conversation. You just conduct the interview and exam, probably like most people have experienced when you go see your primary care physician or advanced practice provider. And you just have that conversation. When that conversation is done, or when it is the visit is concluded, you basically end the recording and you push a button on the app and it sends it to be processed. The processing takes on average about 30 seconds or so, sometimes faster, sometimes a little slower if it's a really, really long visit. But then it returns a draft of a specific clinical note that you then read through, you edit for clarity or for anything that you want to make sure is there, and then you're done and you sign it. There's also some additional functions that are available, like patient instructions, if you were to choose to use them, where it writes out patient instructions based on the conversation that you had with the patient, and it tries to change those instructions a little bit so they're a little less medical and a little bit more focused on patient-friendly verbiage. And then finally, you sign it. So that's the workflow.
All right, so just a quick question. So that means that the doctor, physician, whoever is no longer staring at their EMR screen, correct?
You got it. So that is actually one of the, so I'll get into this a little bit, but we did a pilot when we started about 2 years ago. And that was one of the things that we routinely got back from our patients, is that they felt like in some cases, the first time that they had undivided kind of attention. And being so I do hospital medicine, right? So I'm visiting patients when a ER colleague of mine has determined that patient needs to be admitted to the hospital. So it usually means something serious is going on, right? And I can say utilizing this technology for me personally, it decreases like the cognitive switching that you have to do as a physician as you're going through that. And you can really just focus on that conversation that you're having. I feel like I'm running around, but when you're actually interviewing a patient, it's like one-on-one, or maybe with their family. And I think it's an incredible experience for the patient, but it's like a win-win, because it's also an incredible experience for many of our physicians and APPs, because it kind of just takes stress down, and we'll show data to support this. In being able to just be there in the moment. And I know it's taking notes for me. And if I don't quite remember something, it's there. And it's interesting to look back on, over the course of the past, 12 to 13 years for me as an attending, utilizing this technology. It's very clear to me that there were things that I clearly missed. Because I'll read notes now and I'm like, they didn't really say that, right? And then I look back and I can literally listen to them. Yes, they definitely said that. I just was in that moment in time thinking about what order am I going to place, or what, you're always kind of trying to stay ahead.
Thank you.
Yeah.
Can you give us maybe just your own personal historical context? Let's say 10 years ago.
Sure.
So you're a hospitalist, which means you're essentially rounding on patients that are in the inpatient setting. A sense of, let's say you spent 15 minutes face-to-face with the patient, about how much time 10 years ago were you spending documenting that visit, and also the time between the actual face-to-face and when you were doing your documentation. as opposed to where you are now, you feel?
Yeah, I might go back,
Anecdotal.
so we'll be able to go back about 13 years.
Okay, 13.
Because I think my experience is important. So, when I left residency at Fletcher Allen at the time, UVM Medical Center, they had been live on Epic since 2009. So for about 4 years. So that was I had as a medical student kind of a pre-Epic exposure there. And then as a residency, the only thing I really knew was Epic as their electronic health record during the 3 years of my training. Okay, so I was very comfortable with that system, efficient with that system. It kind of, you spend a lot of time with it. When I left Fletcher Allen and went to Central Vermont Medical Center, the systems that they had were completely different. They included paper. They included a telephone that I typed my own code into and the code for the note that I wanted to make. And I distinctly remember my neck being extremely sore that first year because it was kind of like this all the time as I was dictating. But the challenge was the way that I had been trained was different because I was very used to kind of crafting a note episodically, as opposed to when you pick up a telephone. I don't know if there are others in the room that have done this, but you kind of need to go from the start all the way to the finish. It's not something that you can kind of do part of, put it down, go do a whole bunch of other things, and then pick it back up. That's very, very inefficient. So I had to retrain my brain a little bit in that new system. The other systems that I encountered was just a completely different EMR. So CVMC used Meditech at the time. Our emergency department used HISES Pulse Check, so a completely different system, didn't talk to each other. So when the patient, moved from the emergency department into the hospital, we had to kind of navigate both of those systems. And then I also had to literally write down the orders that I would place as the attending of record for that patient onto paper, which was a whole new experience. And then we would have pharmacists or unit secretaries who would then transcribe those orders into Meditech. And that's the way it was. And the way that I started in informatics was actually my hospitalist medical director at the time saying, hey, we have to do this thing called CPOE, which stands for essentially the providers put their own orders in through the computer. Computer provider order entry, there we go. And IT needed a little bit of help to design the system so that it was usable for the providers and that we would, be able to, continue to do the things that we needed to do. So it's a huge change as I made that. And then we, over a sequence of years, implemented a whole bunch of different solution sets within the electronic health record to help move along that continuum. So it wasn't exactly, I'm going to get to the question that you asked, but that was kind of my experience moving from Fletcher Allen, UVM Medical Center, CVMC, and then over the subsequent 6-7 years, kind of moving now back into an integrated Epic system that is basically the same between CVMC, UVM Medical Center, and Porter and our ambulatory practices. And I should have mentioned that all of the ambulatory practices, so the family medicine physicians that patients would see, cardiologists, et cetera, were on a third system, also called eClinicalWorks. So that's a third thing that you have to log into that all looks completely different and information is stored in different ways. So that was the start. As far as how much time does it take, I think for me, I don't know that the total time that you spend on an admission with a patient has dramatically changed. For me, typically, every patient is different, but it typically takes about an hour to do a full review, see the patient, synthesize your plan, communicate with consultants if that's appropriate, and then do all of your documentation. Sometimes it takes longer, sometimes it's a little bit shorter, it just depends on the situation. But the way that I spend that time in 2026 is very different than the way that I spent that time in 2013, because I spend a lot more, I would say about the same amount of time with the patient and their family, but I've now shifted. So I spend more time on kind of the chart review and putting together the patient's medical story based on the documentation that's within their chart. So I'd probably spend maybe a little bit more time on the orders than I would have with a piece of paper where you kind of just check. But then there's a whole downstream impact of that, because then there's a lot of calls back and forth and clarifying orders and that type of thing. So I don't know it's dramatically changed, but I think that the way I spend my time is a lot better than it was in 2013. And the information becomes available to all of the care team members and importantly, the patient, honestly, because these things become available to the patient almost instantaneously via patient portals. And that was never the case, when we were on paper.
Right. Do you feel that although the time you're taking is not the same, the actual time, do you feel like you're more connected, engaged, and available for the patient in the time that you have? Like, do you feel that your mental capacity, that doesn't sound right, but like, you know what I mean? Like your brain space, your focus, thank you, has changed at all?
I
Not
think-
that you weren't always
Yeah.
attentive.
No.
That's not what I'm trying to imply.
I'm trying to figure out how to answer this the best way. So there are a lot of really good things about digitizing our healthcare records. There are things that we can do today that you cannot do when it is a huge stack of papers that literally physically travels around, following the patient from site of care to site of care. The past 15, 20 years, though, of that journey through, really, a lot of investment that was made by our country through the Meaningful Use Program in digitizing patients' medical records has not been friendly to physicians and APPs and all of my colleagues. And as an informaticist who has implemented these, I significantly feel that. Okay. It is, I would say, easier to check a whole bunch of things on a piece of paper than to put orders directly into the system. So I agree that the experience of providing care in that continuum over the past 15 years, if you're looking at kind of the median physician or APP, has decreased. Okay. And that you may feel, and I think patients feel it as well, that their care provider is kind of connected to this thing. And I mean, there's many of you may have seen it. There's a great illustration that was put into place in the American Journal of Pediatrics from a young patient who did a drawing basically of her pediatrician. And I think it's from the early 2010s. And it's literally this drawing of a pediatrician like staring at a computer on a wall with her and her family off to the side. And it's really powerful because that's her impression of what that encounter was like. Right. And so I think I want to set that stage because in the subsequent slides, I'm actually going to tell a little bit of a story on how that can change. And I am really hopeful will change if we're able to effectively adopt some of these technologies. And within, set guardrails, because our North Star is always making sure that they are safe, that we protect patient confidentiality and data, because it is ultimately the patient's information and they should be choosing who they share it with or who they share it with. And that we implement these things very thoughtfully across the entire care team. Okay.
Leslie, and let's get to that.
Yeah.
Let's get to the rest of the slides.
So on your second slide, you talked about coding recommendations.
Yes.
And I've heard sort of whiffs about upcoding and how that, and you may not want to answer that now necessarily, but that's sort of an issue that I've heard about.
Yeah. So the way that the system that we use, Abridge, works is it uses very specific criteria. It's called NEAT, N-E-A-T criteria, NEAT, M-E-A-T criteria. And it leverages some algorithms to make a recommendation that based on the criteria that's put forth through the coding recommendations, this office visit or follow-up office visit would be recommended to be a level 2 or a level 3 or a level 4 or a level 5. So I think, but it is always a recommendation. The ultimate decision is first, at least in our system, based for the provider that is seeing the patient, and they will put in a code. And then depending on the situation, there may be a professional coding review as well that goes in and determines whether or not the documentation that is supplied as part of that encounter meets the criteria for those various different levels. So I think actually has the potential to improve the accuracy of the coding, in totality, when you're looking at the entire population.
We're of course very worried about the costs of care in
Yeah.
Vermont, so that's why I bring it up, is how is that gonna imply, but we don't have to go there. But it is, I think it could have impact.
Yeah, I think our goal is to make sure that the documentation, the diagnostic coding, and any coding, whether that be professional coding for, submitting a bill for the services that you provide, is as accurate as possible.
Okay.
Okay.
Thank you.
So when I talk about at UVM Health, I just want to give you a really high level timeline. So we started looking at this just over 2 years ago. This is when this technology really kind of took a leapfrog. A lot of the technology when it came to scribes was really human scribes. You either had and maybe some of you have experienced this, where the provider may have a third person in the room with them who is taking notes or typing on the computer or doing those sorts of things. And that's a difficult thing to scale, right? Like it's difficult to hire, it's difficult to afford, it's difficult to keep in some cases, because it tends to be a position that people take for maybe a year as they're preparing to go to medical school or PA school or things like that. And then they kind of move on. So you're in this constant like turnover experience. Around the fall of 2023, the technology got to a point where we were feeling like, yeah, there's really something there. We want to look at it deeper. We did a pilot that I referenced from February to April with 2 different providers of this technology at that period of time. We trialed it with 50 different primary care providers, so both physicians and APPs across UVM Health Network. So it wasn't just located in Chittenden County, it was really any of our primary care practice sites, including family medicine and general internal medicine. And then they utilized each system and they crossed over after 30 days. And then ultimately our medical group governance made a decision to move forward with Abridge, which is our provider of this technology until today. We signed a contract with them. We did some research over the summer of 2024 that I'm going to talk about in a subsequent slide, utilizing AHEC medical students, actually. So great program there. And I want to do a call out for that to really ask the question of what is the note quality compared to a human? And we'll go there. And then we really had a sequential rollout. Because it was new, we determined that we wanted to be very purposeful in how we rolled this out. And so we kind of went clinic by clinic by clinic, provided support, provided at the elbow training, and really tried to coach as much as we could to the providers as they adopted this. I will say 2 years later, the rollout strategy for this is now completely different. It is a fast rollout because we have learned that we're able to scale this very, very quickly. And then really, in about a year ago, a little under a year ago, we went live in the emergency department so that the entire emergency department clinics could leverage this technology, and they've been utilizing it since then. And now we're kind of more in a steady state where we're looking at the functions that are coming out. We're starting to ask questions around our providers that are not adopting this, and are they missing something, or are they just happy with the way that they're documenting today? So that's kind of where we are in our rollout.
Is UVM still using scribes, like human scribes?
I know that there was a scribe program in the emergency department at UVM Medical Center, and I believe that has stopped. There may be some pockets of scribes in the ambulatory setting. I'm thinking about like ophthalmology. We can provide a follow-up on that if you'd like.
I know they're doing it in the ophthalmology because I was there yesterday.
Okay, perfect.
Oh, you're right.
Yeah.
Maybe we should do the thing that.
I didn't even see one, I don't know.
Right.
When you say ambient rollout, are you referring only to the clinical voice component of ambient artificial intelligence use? Or are you also talking about the other components that are out there, such as sensors on patients that the medical record system is documenting, and is the optical sensors where there's optical sensors. So if you don't know what this is, you're probably not using it yet, but where there's actual cameras filming things and then the computer's tracking that. Is all that a part of this?
No.
So UVM is only using the clinical voice component, or is this a different company than the ambient Because like if you look up online, there's lots of articles from like the Institute of Health, et cetera, the National Institute of Health about ambient intelligence, technologies, et cetera.
So when its current state today, when I talk about ambient, what I'm talking about is the recording of audio only, so there's no video involved in any of this. That then is utilized to generate some amount of information that is then passed back to the provider where they edit it and then they
The
authenticate.
large language model or what you call, yeah. And then, what is the company? What is the corporation or the product called?
So the company that we have contracted with is named Abridge.
Thank you. That's helpful.
Abridge. They're out of Pittsburgh, so that's why they're named Bridges, because there's like 100.
Abridge?
Yeah.
Okay, thanks. I want to keep moving. I just wanted to ask that now because you're talking about rolling out ambient and I was just not sure how you were defining ambient, but it sounds like we're really sticking to this one component available. Right, thank you.
So this is our user growth. So on the left-hand side, you can see this is the number of encounters that were done with this technology by month from the beginning in February of 24 up until April of 25. So we went up to just under 25,000 encounters per month over that time frame. Same thing with our recording users. So this is the gradual ramp that I talked about. So we went up, 350, 400 users over that time frame. Yes.
How many encounters of the denominator?
Total encounters that we do.
You say 25,000 in April, and I'm just wondering what the denominator is.
So I'll have to get back on the exact number. We do, I believe it's about 1.2 million ambulatory encounters per year.
Okay, so
So 100,000-ish a month.
so this is 25,000 per month. Is that what you're saying?
Yes, and actually it's gone up since then.
Yeah.
So these are more data, the way that we recorded it changed, so that's why it looks different. But
Sure.
so you can see we kind of hit our all-time high in October of last year. So we hit 43,000 at that point. You see a little dip. You always see this in November and December because of the Thanksgiving holiday and because of the Christmas holiday. So the number of encounters just kind of goes down. We'll see how, what January shapes up with. But now we're at this kind of 40,000 encounter per month number. And we continue to see it is definitely leveled off because I think we have some saturation, but we have in December, it was 673 individual providers that had logged in and used it at least once.
And what's the denominator there?
That's a really good question. We have around 1,200 physicians and APPs as part of our integrated medical group. And then we also, residents are able to utilize this technology. So you need to add another just under 300 or so to that. So the total number is around 1,500, but this is not targeted at all provider types. So there are certain provider types where it just doesn't make sense, like pathology, radiology, anesthesia,
So
a whole bunch of them.
clinical provider.
I estimate it's probably around 900
Mhm.
that is like the total marketable.
So you're getting 2/3.
Yeah.
Sounds good.
Yeah,
Yeah.
it's and it's not for everyone. Like there are some people who are very happy with the way that they die.
Yeah, for sure.
and
Once
this
you
is-
get into your routine.
This is a thing that is nice because each provider can choose what encounters to use it on and if they want to use it at all. So I had mentioned the AHEC report. So this is available. There's a link here if you want to click on it and look at the entire poster. So big call out to Edward, Francisco, Michelle, and my colleague Alicia Jacobs, who is actually the clinical lead for this program and is one of my informaticist colleagues. But basically what we did was we took notes from that initial pilot and we used a standardized scoring mechanism to look at kind of matched human-made notes, the notes that were made with Abridge and the notes that were made with the other vendor that we evaluated. And they looked at various different categories that are listed here. And in short, what they found is that they were non-inferior. Like they were on those categories when you put it all together, the quality of the note was about the same.
This was just on the pilot, correct? And the pilot was 50
Primary care.
primary care providers. Was an analysis done in the pilot to Leslie's question? Was there a comparison to non-Abridge users and level of coding?
Level of coding, no.
I will say,
This study,
to her
this,
question, when this was up last year, the rollout of a bridge coincided with a huge claims surge, which put our only domiciled insurance company in peril. And it was based upon acuity
Mhm.
and utilization. And that was driven by one health network.
yeah, I don't think this, yeah.
There was a concern because
Understood.
we were aware that this was being rolled out.
Yeah. I don't believe this is what's driving that. But a lot of what's driving that, to my understanding, is really around the volume and the number of services provided, as opposed to, we had a large number of services that would previously have been coded as a level 3 that are now a 4 or a 5. We're not seeing that kind of change in RVU that would account for that type of delta.
Yeah.
So, yeah.
Are patients informed that generative AI is being used in their medical records explicitly, or do they just come in and do the visit and they're not told that they're actually being recorded in person because I looked ahead in your presentation just to not ask a question that you're going to answer, and you talk about the presentation talks about how currently the issue is that in telehealth, you can't record people to use this, but in person, there's nothing prohibiting recording them. So they are being recorded right now.
With consent.
Yeah, but are they being told that generative AI is being used explicitly?
Yeah, so we provide guidance that at the beginning of the visit, we need to get permission to do the audio recording. And I would say most of my colleagues, you get very used to kind of that phrasing, and most will say, I use a secure, you'll see in the demo, actually. Okay, I'll share the way that I do this. And it's really so that there's a recording happening, and it's going to help me generate the clinical note so that I can focus on you during the visit. I would say most people do not go into extreme detail about AI and exactly how that works. We have done a lot of due diligence around this company and their technology generally, that we are comfortable with the way that they leverage it. And for many visits, they're short. So you want to kind of balance, like, how much time do you spend starting this versus getting into the meat of why the patient is there to see the provider. So these are our outcomes when it comes to provider burnout and provider professional fulfillment. And so you can see at the beginning of, and this is not unique, we have data that is outside of the pilot participants, but this is the most robust data I have thus far, and we're going to survey them again in a month or so to get our 2-year data. But you can see before entering the pilot, 69% of the 50 primary care providers reported significant signs of professional burnout. Within 8 weeks, that had dropped to 38%. Within 4 months, it went down to 24%. And then 1 year ago, which was just under 1 year ago, it did rebound a little bit, but nowhere near the to 36%. So at 1 year, we see a 48% reduction in burnout rates for this particular cohort utilizing this technology. I want to express this is not repeated anywhere else in any type of burnout intervention that we are able to provide to our providers. Before this, if we got 5% delta, 10, like small, we're like, this is good. We're really making progress. This is life-changing for some of our providers. These are conversations that I have with my colleagues that they don't want to retire early anymore. They enjoy going to work. They are able to leave, go to a soccer game for their kids, engage with their spouse at home. Like all of those kind of real life impacts, it is real. I had in this pilot group, honestly, some providers were panicked that we would take this away from them because of the impact it would have on how they practice and the overall professional quality of life that they have. So it is really fundamentally changing how they interact with their patients and how they experience delivering care. And these are frontline physicians and APPs seeing patients every single day. And the best way, in my opinion, that we can increase access is to reduce the continuous decrease in clinical FTE that our providers experience because they are burned out and they are not able to see as many patients as they want to see in a given week. They work incredibly hard. Okay. We see similar results when it comes to professional fulfillment. The Stanford Professional Fulfillment scoring system is a validated scoring system. Again, we see pretty notable increases there. So in my role and just generally, I think security and privacy of our patients' protected information is one of the most important things that we do. We have at UVM Health, we have a number of systems in place to guard against this. So in one case, all applications that come into our IT environment undergo a rigorous security and privacy assessment before we even engage in contracting or certainly bring that application into our environment and deploy it to our end users. Any technology which involves artificial intelligence goes through a specific council that is multidisciplinary. I am in full transparency, I am the co-chair of that council. And we have an intake process for not only the vendor that is providing that technology, but importantly, also the business, we call it the business owner, but the accountable person within our organization that will be deploying this technology in the care of patients or on the revenue side, so that we understand how they plan to monitor for the effectiveness of that technology. What is the report out period going to be? What are their measures going to be? And then, we ask them questions about that based on how they fill out that business owner questionnaire. So that is our AI council process and that's been in place for just over 2 years now. We review all of our contracts very, very closely with an eye towards patient privacy, security, and data use. And then specific to Ambient, the recordings for this and the transcripts are retained for 30 days because that provides the amount of time for providers to be able to go in and make the edits that they need and finalize them. And those are no longer available after 30 days. A subset of those, this is in our contract, are able to be de-identified by a bridge, and they are only able to utilize those de-identified recordings or transcripts for improvement of their system. So making it so that, their algorithm performs at a higher level that requires less editing by our providers. So there's a small subset that they utilize for that after a fairly robust de-identification process. Okay. So lots of questions along the way, which is great. But
Right. Go ahead, Brian.
Yeah. I looked and I just want to confirm that because UVM Health Network, or is that still the name?
UVM Health is now the
UVM Health, sorry, because it was switched around when I first started working in the emergency room, so it changes. So I'm going to be sensitive to the official. I don't want to misidentify you. So UVM Health, because you are a private organization, even though you intersect with the public, like healthcare, like you're a private organization, you're not an extension of state government. You're not required to report the use of AI on our inventory, on our state inventory. And I just reviewed it and I don't see a bridge on there. So I don't want to get into it now because I want to do the demonstration, but I am curious if maybe later we could hear testimony or you could follow up with us on if your AI council internally is using the same standard as the state AI council, because we have an inventory with in statute required disclosure to the public of certain attributes of any use of AI by government. You're not required to do that yet, but you may be doing it already. So if I forward maybe to Devin, like a link to the state inventory, it'd be interesting either to hear testimony later or some follow-up. You may say, oh yeah, we do this. We answer all these questions, or you might say, we don't, or you might say, oh, maybe we should, or whatever, but that's a remaining question I have that I don't want to get distracted by because I want to do the demo, but I can send it to you. But if you're not aware of the inventory, that would be if you're not aware that exists, then that's a sign that maybe, it's time that we start those conversations, that the state's doing it, maybe like state funded efforts like healthcare need to have a similar standard, I don't know. You may already be doing it. You may have a higher standard.
Let's get started. And I just want to give a caveat before, and I'm really sorry to miss this. I have to run here in a couple minutes, so I may walk out in the middle and Topper is going to take over.
Oh, yeah.
Okay,
Our show.
so let's get started. Leslie is the patient.
Okay,
Oh, there's only one.
so I can't show you my phone, but it's really boring. I basically hit a record button. That's the only thing that I do with my phone. I want to say, this app this is my personal Android phone. It works on iOS, it works on Android. The app is containerized, so it is completely secure within my phone, and the authentication happens through our system. So you cannot access the app without having an active account within UVM. Okay. And I'm only going to be showing you the abridged portion. We have our preferred workflow is actually fully integrated within Epic and their particular, but the concept is exactly the same. Okay.
How
Leslie.
complex do you want to be?
We do not, I know, I'm a little nervous right now. So let's shoot for like 5 minutes. And, does that, you can choose some
Sure.
benign.
Well, I could be benign or I could be benign.
Whatever, I am game with you. So, Leslie, right?
Yes.
So Leslie, thank you for coming in today. Before we get started, I use a secure app on my phone to record our conversation. It helps me with documentation. It'll give me a note back and I'll review that note, edit it for accuracy. And then once I sign it, it'll become available to you on your portal to review. Would it be okay if I recorded our conversation today?
How long is it on the portal?
How long is it on the portal? Your note will be on the portal. For us, we don't ever delete notes off the portal, so forever.
Thank you. Yes.
Okay, great. So what brings you in today?
I have a cough,
Okay, and how long has that cough been happening for?
about 3 months.
Oh, geez. And how severe is it? Is it something that, you're not able to sleep, or tell me a little bit more about it?
I get to bed at night, but sometimes it's with exercise, or cold air.
Okay. And does anything, you've mentioned cold air seems to make it worse and exercise. Anything else that has made it worse?
Mm-mm.
Anything that's made it better?
Halls.
I'm sorry?
Halls.
Halls.
Drop.
Oh, calls. Cough drops. Got it. Okay. And have you ever experienced this before?
No.
Okay. And any other symptoms that you've noticed in addition to the cough?
I've had some weight loss, not necessarily intentional, but appreciated.
Gotcha. And how much weight have you lost?
About 15 pounds
And over what period of time?
for 3 months.
Okay. Any other symptoms that you've noticed?
Occasional sore throat.
Sure.
No, other than that, no. Maybe fatigue, but it's a busy life.
Yeah, I'd like to ask you a couple other questions if that's okay. In addition to the weight loss, have you been experiencing any fevers?
No,
Okay. And do you ever wake up in the middle of the night sweating, or maybe your sheets are drenched with sweat?
no,
And have you been coughing up any sputum or anything abnormal out of your lungs?
no,
Okay. Any problems with your sinuses or your ears or your mouth?
I've had to clear my ears more frequently than before,
Okay.
but they clear.
All right. Any chest pain?
Occasionally, but not necessarily related to the cough.
Okay.
That was fun.
I'm going to talk about the chest pain just to keep us in a time-bound box here, but and no shortness of breath or things like that.
No.
Okay. And do you have any medical history that I should be aware of?
No, I do have gestational diabetes.
Okay.
I did.
You had gestational diabetes, but you haven't ever been diagnosed outside the gestational or post-delivery period with diabetes or prediabetes?
No,
Okay. And do you take any medications on a routine basis?
I do.
What do you take?
I take Tylenol and gabapentin.
Okay. Do you know your dosage of gabapentin?
I do.
What is it?
Whatever.
Okay, so you take 600 milligrams of gabapentin 3 times a day.
300, 12. What is it?
It doesn't have to be real.
Something like that, yeah.
Okay, all right. And are you allergic to any medications?
No,
And I'm sorry, I don't remember if I already asked this, but do you have any other past medical history that I should be aware of?
no,
Have you had any surgeries?
yes.
Okay, and what kind of surgeries have you had?
A list, I mean.
Okay, so quite a few.
I don't need to say it here.
But no surgery, it doesn't have to be
I
real.
can
You
make
can,
it, I know,
you
but
can
it's
completely
easier
make
just
it
to
up.
think about myself.
So we'll say no surgeries.
Okay,
And where do you live?
Vermont, in southern Vermont?
Okay, and do you live with anyone?
No,
Okay, and do you have any pets in the house?
a dog.
All right, but you don't have any other exotic pets, no birds, no other things like that?
No.
Okay. And have you had any recent travel?
Yes, I've been to Papua New Guinea.
Papua New Guinea? Well, okay, when did you go to Papua New Guinea?
4 months ago.
In November.
In November. So was that about the time that the cough started?
No, I think it actually may have started before that.
Okay, all right, and okay, thank you. So I'd like to go into an exam now. What I'm going to do is I'm going to do a physical exam. But
Yeah.
what I'll do is I'm going to speak through my exam. So it's going to have some medical terms, and you can ask me any questions that you want along the way. Would that be okay?
Yes.
All right. So your head is atraumatic, your eyes are anecteric, your pupils appear to be equal, they're reactive to light, your oral pharynx is clear, I don't see any pharyngeal exudates. I'm palpating your lymph nodes. I don't feel any lymphadenopathy. There's no lymphadenopathy of your cervical, clavicular chains. I'm listening to your lungs. They sound completely clear to me. I don't hear any expiratory wheezes. You have full breaths. Your chest rise is symmetrical. Your heart rate is regular. There's no murmurs, rubs, or gallops. And your abdomen is soft and untender without any organomegaly. I don't appreciate any rashes or joint effusions. You seem to have movement in all 4 of your extremities with equal strength. Your face is symmetric. You seem to be alert and oriented ×3 and are responding appropriately to all of my questions. So I'm not sure what exactly is causing your cough, but I would like to do some additional testing to try to get to the bottom of that. Would that be okay?
Yeah.
All right. So the first thing that I'm thinking about is that sometimes when you have chronic cough, it can be undiagnosed, something like an undiagnosed asthma. Have you ever had asthma or have you had wheezing with this?
No.
Okay. So maybe in the office here, I'd like to do a brief spirometry test just to see if that shows us anything that could help us understand what's the underlying cause. I'd also like to get some basic blood work for you. So we're going to have our phlebotomist come and draw that. I'd like to just start with a simple CBC and a complete metabolic panel, and then we'll kind of take it from there as a start. Would that be okay?
Yeah.
All right. Was there anything else that you wanted to talk about today?
No, but I thought your physical exam was scary.
Okay. Is there anything that I can help
The way
with?
you do, yeah. I mean, if I were a patient,
Yeah.
that would be like.
And I'm
oh.
rushing a little bit here to
No, I
be
get
quite
it,
honest.
but, and it carrot blah, blah, you know,
Yeah.
that's a lot
Yeah.
for someone to take it.
It's funny. Each patient responds a little bit differently to that. Some like it. Because
If they know what it means.
So, yeah.
Do you ever, is this still?
So it is recording, so let me just hold on one second. So the other thing I just wanted to show, if we banter a little bit, so that happens in the doctor's office, I'd really like to know, like, what did you think of the playoff games and that type of thing this past weekend? It does quite a good job of kind of stripping that out from the clinical one. Okay. So I'm actually going to stop the recording. We're at 7 minutes, so not bad. So the recording stops. I just say create note, and then I can show you here in a second. It looks like I lost my share.
Ask a question.
Please turn it back on.
Send request. Oh. Okay. Yeah, go on. Shoot for that. Did you have another question first or?
Can I be next?
Free
I
class.
do a mental health evaluation on Penny, the demo, just to see how it responds to mental health questions, like, that's not an insulting thing. I would love to use that and see how it actually writes a mental health note, but that, not to digress down that road. Do you find that sometimes because you are narrating what you're doing, it's actually an opportunity to educate the patient about their own body?
Absolutely.
Because I can see that benefit, like actually explaining what it means to them, and they're learning about their own body, then they're like, they might notice something in the future or develop hypochondria, but like, they're me, but.
So, different physicians and APPs have different experiences adopting this. You do need to, many people need to change the way that you conduct your interview because it doesn't read your mind, right? There is no, Neuralink sensor in your brain to tell it exactly what's happening. It requires you to say out loud what you're thinking, what your assessment is, and what the plan is. And for some of our providers, it's like super easy. They already do that very, very well. They don't have to change anything to get a really comprehensive good note that they're satisfied with. Some of our providers do need to change a little bit in the way I need to do this, in the way that I walk through kind of my assessment and my plan in order to generate the note that I want to generate. And that, in my view, is actually a really positive thing because it actually the technology itself, and I believe, can actually improve that communication piece because you may have thought that you said it, or you may have thought that maybe the patient walked away understanding it, but they maybe didn't. And so this actually, to get that good note, it really does require you to articulate exactly what you're thinking, exactly what you're finding, and what your recommendations and plan are. So I don't know, Brian, does that help with the question? Or?
Oh, yeah.
Any other questions?
Thank you.
So
Sorry. You said that it can translate all your medical terms
yes.
for me if I don't understand. Does that happen?
Well-
Like, is that a printout? Or is it?
No. So it won't, I am happy to explain to a patient my medical terms, but I want my medical terms to be present within my physical exam. That's how we communicate as care team members using very specific language. So for me, when I'm talking about my physical exam, that's really important that is captured, within the documentation. Okay. So this is the note that it made. This is always a little risky doing this.
I
So
thought that looked pretty good.
So far, so, I mean,
Yeah.
it's not done yet. I'm curious.
Yeah.
Oh, here we go.
And the Papua New Guinea part is tricky because there's endemic TB.
I like how it naturally, I like how
I was
it's,
like, oh, good, where are we going?
so it's naturally sorting information into predetermined categories that are part of your note. Yeah, I like that. That's
Love
great.
it.
So, and I want to, the physical exam, there are different selections for the provider. So you can actually, the way that I do this, I chart by exclusion. So I have kind of my standard physical exam, and then I will delete out things that do not make sense or that I did not do. And then it will add things that I found. I did a very normal physical exam, so it's not this, I could have done something a little different in hindsight. I didn't review any active results, but if I had said, these are your labs, this is the result of your chest x-ray, those types of things, it would show up there. And then this is its assessment. And so, what I would do at that point after reviewing all of this is making sure that it's accurate. And then I would make any additional edits that I felt were required.
When do you do the review? Right away or later or?
So as a hospitalist, my focus is actually getting orders in on the patient so that they can flow through the emergency department and up into the
Right,
medical
okay.
floor. So I will tend to do the review at some point later. Sometimes if it's very, very busy, it may not be until hours later because I'm really focused on that flow so that we can deload the emergency department and the patients who are waiting can be seen. In an ambulatory setting, there may be some variability in the workflows that they use. Some providers will, I'm certain, do it right there when the
Mhm.
patient is there. Some will do it kind of in that in-between time between patients rooming and that type of thing. So there's a little bit of variability. Some will do it later in the day or even not the same day. We really like to see notes completed the same day. This has helped with that. So we've seen some really great success stories where people are closing their notes days, what far too long, into the future. And they may not get to the point of closing them the same day, but they're moving from sometimes, double digit day counts into single digit day counts, and that's meaningful.
I follow up real quick. So
So once you're-
Over here after that. And then Daisy, you have a question?
So I'm going to stop my share if that's okay, but I think you get the idea of
Yeah.
how it's.
Oh, yeah, I'll get in line. I get in line.
So my follow-up to that is, before this, depending on the physician, they still could have been taking days to review notes.
Correct.
So that's not an issue that like it might, probably has helped speed things up.
There are,
Doctors remember.
yes.
Okay.
There are some of our providers that this has made a really meaningful difference in their days to their notes being signed.
Okay, thank you.
Significant, like days and days and days. It's really-
Great.
You can't build till you're done.
that is one of many, the accuracy of the medical record in my view is the primary reason, but you're absolutely right. You cannot bill until that chart is closed. So having a chart open for 20 days is not helpful for anybody.
So I'm just looking at privacy. So it looks like there's two pathways. One is that Ambient only retains it for 30 days as opposed to the EMR. So that you were referring to the EMR that it's always present, whereas Ambient,
That's right.
so scrubs it or wherever it goes.
Yeah, and
But I would think it would be hackable or not, or am I being paranoid?
I mean, I think they use very strong security
Mhm.
precautions. I mean, in this day and age, you can't say
That's
to
what-
Six Sigma that nothing can ever be hacked.
Yes.
But the Abridge, met all of our requirements as part of that technology intake review. And I know that they, like us and like Epic and others, are very focused on making sure their system is as bulletproof as possible.
And I have a question for Jen, if I may. So there's only one line being added, right? And so we could not do this legally without changing the statute. Is that the point? I'm just trying to understand
So
what yeah.
I have one more slide, actually,
Oh.
if I could go to that. Would that be okay?
Sorry.
Because I think that might help answer that
Okay.
question. Or gently. So, sorry, I gotta get back to. Okay, so why? Here we go. So why HR 84?
Oh,
Right.
that's-
Is the question, and I included kind of a leaflet from the Vermont Medical Society and our Academy of Family Practice colleagues, because this is very important, I think, to providers wanting to utilize this technology across the state. So the issue that we have is our reading of the current statutory language is that this would constitute a recording, and therefore we cannot record as part of our telehealth visits for the purposes of generating this documentation. So that is the reason. We have a sizable number of our providers that do telehealth visits. It's good for providers. It's good for patients. Some of our highest users are, in our psychiatry, psychology areas. We also see it used highly in places like oncology. And so it is a major dissatisfier for our providers that in one care setting, when a patient is in front of them, they are able to utilize this technology, but in another care setting, they are not able to utilize this technology. And so if you put yourselves in their seats, that doesn't really make a lot of sense to them. And it doesn't make a lot of sense to me either, honestly. So our goal is really just to allow the use of this technology, recording that audio interaction, whether there's a video associated with that or not, to help our providers reduce burnout, increase professional satisfaction. And I think those are all, aims that we all have while making sure that we're utilizing secure systems at the same time. So this is the why.
So if I may, so the ... in the bill is where that language says we can't do it. The extra, yeah, the ellipsis is.
When you look at the bill, you can see there is the language there that isn't the underlying language, but it's showing in the bill says nobody can record a telehealth or audio only visit. That's the part that currently says you can't record a telehealth consultation.
Okay, so that by adding that line, it changes that above
Right.
clause. Got it. Thank you.
Just, I don't know, just theoretically, do you have any sense that this makes life a bit easier, but so much easier that the scrutiny of the chart as it ends up happening with this technology, that they go, ah, it looks pretty good. Or is that really intense scrutiny of charting, still present? And then if the ambient recording disappears within 30 days, how do you go back and go, oh yeah, I missed this, or that's there, or whatever?
So,
Just-
so there's certain, standards around what's called the designated record set when you're talking about medical records, right? And so the product that is part of the designated record set and recording of that visit is the clinical note that is signed and authenticated by a licensed healthcare provider. So that is the note, and that is the record of that visit from a designated record set standpoint. And that's why that is kept, we don't delete anything, but there's, I believe, statutory policy around how long you are required to keep that. And it's like 2 years, if so, don't quote me exactly. But that is the legal record, and that is what the licensed provider is attesting by digitally signing that they, under their license, are documenting the contents of that visit. Okay. The storage for 30 days is a transitory kind of thing that allows that provider then to take that initial draft, edit it, and then ultimately apply their signature and therefore their license under however they're licensed to that document. That
Just before you go, Daisy.
I'm good.
You good?
I'm good.
Does that information go into the patient's record?
which information?
Ambient,
The actual audio recording? No, it does not.
doesn't. So you put different information, patient record.
We're putting the documentation by the licensed provider is in the patient's record.
Should know, so.
Yeah.
Okay. Thank you very, oh, I'm sorry.
It's okay. I'm sorry if I missed any of this, but does does UVM Health's use of a bridge include any of the following? Flagging of any missing pieces, like does it say, you didn't ask this, you didn't ask that? There's 3 things, so that's the first one. Is it like, does it give you any warnings, like you forgot to ask about social history? Or does it, if you don't ask, it just leaves it blank,
No. However, on the roadmap for many of these companies is inclusion of things like decision support and nudges for those
Okay.
purposes. But it is not an active feature, and that is something that we would evaluate if or when it becomes available as a feature.
Yeah, and there's 2 other things like that. So my guess is you're gonna have the same answer, but I'm gonna ask anyway, instead of assuming that. Does it present possible diagnoses, and does it make treatment recommendations?
It does present diagnoses.
It does that already.
Yep, it does present diagnoses today that are editable, and you can basically select and it'll give you similar, so clinical diagnosing is really complicated, and there are tens of thousands of different diagnoses all attached to different ICD-10 codes. So our goal is always to get the most accurate diagnosis for that patient, but certain things like depression is a great example, is not a particularly specific diagnosis when it comes to the ICD-10 taxonomy. So it will, the ICD-10 kind of diagnostic taxonomy. And so it will present different selections that you can then choose from that would be most appropriate for that patient. I'm not feeling like I'm answering your question.
You are. No, I don't know if you know, I'm a clinical provider. So like you're answering exactly as I would expect. Does it ever say, or maybe not yet, but does it ever say like depression is indicated? Why don't you give them the adult, I'm trying to think of one of the screenings, like one of these screenings.
You didn't do a,
Or like you didn't like, they said this comment that suggests suicidality, do a Columbia, a CSSRS. Like, does it have that kind of feature yet?
No.
Cool. It could though, eventually, which could be a strength. It could like flag things for you to like.
That will happen.
Mhm.
The only thing that's uncertain is the timeline.
Okay. And then I think I might have asked, does it ever give recommendation? Does it say like, you might want to prescribe these medicines, or why aren't, you aren't prescribing these things? Do you want to, or like just to youth, like, does it ever do things like that? So there was an evidence-based practice with float, I might get this wrong because I'm not a prescriber, but it might have been called like medication management or something, where there was like flow charts that doctors would use. This is old. There was like this thing they used to use. You know what I'm talking about?
I think so. So,
Yeah.
I mean, Vermont has a very long history here with Larry Weed, honestly, and I'm forgetting Larry's, originally it was through the Department of Defense, and then it was through a company around providing providers decision support. So for people who don't know, Larry Weed was a physician in Vermont who's very focused on kind of medical records back when they were pieces of paper and how you categorize them. And I can send you all a link, but there's a beautiful presentation that he gives at Grand Rounds at Johns Hopkins in the 1960s. And I really use that as kind of like the birthplace to some degree of how you begin to really organize what is a very, very complicated set of records. And so Larry and his company, basically created a whole set of kind of flow sheet-like algorithms to answer the question of are we providing the most evidence-based care for a given patient? And I think, honestly, he was just early in the technology ramp cycle in that there wasn't the underlying kind of systems to support that way of thinking, and it became unscalable. But the technology ramp cycle has now changed, and we have new tools within large language models, artificial intelligence, et cetera, that make that possible. Now, how you responsibly deploy that at scale in a health system is a really important question, and something that we'll continue to look at. We're not doing it today, but it holds a lot of opportunity because we know that if we can make subtle nudges along the way, or hey, none of us are infallible, in our kind of like diagnostic journey. If it is a aid to the licensed human that also brings judgment, compassion, experience, all of those types of things. Those two things, when you put them together, can be very summative, and it can really result in better outcomes. But it is a little bit early because I don't have a particular product to respond to right now. But there are many companies working in that space. Like, how do you do that effectively, impactfully, and in a way that is not abrasive, honestly?
And so this is just an extension of that question, like in terms of the treatment recommendations. If this product, or I don't know what else to call it, if this method of note taking, trying to like use like neutral language so it doesn't like, that's not scary. I mean, it's a method, it's another tool. It's a method of note taking. If this method of note taking evolves in such a way where it can nudge providers or provide instant access to additional screening options, or comb their medical record for information and bring that to the provider in that moment immediately. Like, hey, we found this thing about the patient that they're not telling you. And so you can be like, oh, the chart is saying that, you had a surgery. They're like, oh, I forgot about that surgery like 5 years ago. Maybe there's metal in me still, or I don't know. So I don't know. Like, you get my point. Like that
So
that could improve delivery. I mean, it wouldn't just be like make the provider's experience better, but it could save patients,
I 100% agree.
I'm sorry. Yeah, so the last piece is just precision medicine. Like when it comes down to like, you smile. So this isn't totally, so how do you see precision, or maybe you can explain as the witness what that is to people and how that might eventually tie into this, like when you're doing a screening, how it might.
So my view of precision medicine, I would define, I'm sure there's a technical definition around it, but it's essentially utilizing clinical data that is unique to one individual, right, to guide the treatment decisions that are applied to that individual. And that can be for a whole host of different, that can be based on kind of their genetic profile. So one of them is, pharmacogenomics is a great example of that. Different patients respond differently to pharmaceuticals because of their genetic makeup and how they process those pharmaceutical drugs. So if you know, based on genetic testing, that, Justin is not going to respond effectively to clopidogrel as an example, because I have a CYP, inhibitor, then I would make a different decision about what medication I prescribe Justin. And then you need to scale that, right? Because it's the same thing across a whole suite of different genetic alleles. And then it's also, once you get into specific disease categories, not everybody's non-small cell lung cancer is exactly the same. Each one of those individual lung cancers has its own kind of set of unique genetics and biology. And therefore, you can treat that same core diagnosis, non-small cell lung cancer, with different biologic targets depending on what the actual makeup is of that tumor cell, right? So those are all the pieces that are very, very exciting, very complicated from a healthcare system standpoint, because many of those treatments can be quite expensive, but they can also be quite effective if they are targeted at the right disease process. But then there is a scaling piece to all of this, right? So as you have more and more targeted therapies that are dependent on many, many, many different genetic markers or other, physiologic things, you need some decision, in my view, we need decision support to really say, okay, does this match up for this particular patient? Because it gets very, very broad, very, very complicated quickly. And really what we want to ask the question is, what is the likelihood of this particular therapeutic intervention being successful in this patient for whatever goal that is, right? And you want to make sure that you narrow that down so that the likelihood of success is as high as possible and the likelihood of harm or non-value add expense is as low as possible. And so my technology and some of this decision support that you're talking about is a key component to doing that successfully.
Well, thanks for getting into that. Sorry.
Well, and so can I just, one last thing. So I just want to, great questions, great answers, love it. And I want to ground us back into what this bill does. And this bill is, today we are allowed to record in a person visit. And this bill is saying we want to allow recording in a telehealth visit. That is all this bill is doing. Thank you.
Thank you. Okay. Thank you very much. Appreciate you coming in.
That's great.
Very much. Yes. Excellent. Now, I have some things that we need to talk about.
On the record.
I mean, on the record.
Okay, so it's about policy. It's not like,
Here's what we're gonna do here. Hey, everybody,
Sorry.
Oh, sorry.
tomorrow, 10 o'clock, 84, we're gonna get into that some more. We may even vote on it. This list that you got, look at it tonight. We're gonna talk about this tomorrow. What we want you to do is pick out those areas that you would like further information about. So stay here.
Don't come in and say, these top 15 are my priority.
What if there's things that aren't on here yet that are coming?
No, this is all we'll look for tomorrow.
We'll come back to those other things.
Yeah,
All right, thank
we don't
you.
have them
No,
yet.
we'll come, as long as there's a way to include them later, then I won't worry about
Like
it.
some things came in today.
Yeah, okay.
Well, it's a
Okay.
very good thing.
Thank you.
Okay?
Got it.
Got it.
Thank you.
Anything else? Okay, we're done. Thanks very much.
Can we go out there?